Good afternoon, everyone, and thank you for joining us today for our community conversation sponsored by Johns Hopkins Medicine. I'm Tracy Brazelton, Executive Director of the American Heart Association in Baltimore and Greater Maryland. Today, you will hear from two amazing doctors who have expertise in cardiology and obstetrics and bridging the gap between the two. With us today, we have Dr. Garima Sharma, the Director of Cardio-Obstetrics at Johns Hopkins Medicine and an Assistant Professor of Medicine in the Division of Cardiology and Department of Medicine at the Johns Hopkins University School of Medicine. Her clinical and research interests are in cardiovascular disease in pregnancy, specifically adverse pregnancy outcomes and cardiovascular risks, postpartum prevention of complications from hypertensive disorders of pregnancy, and gender equity. Dr. Jason Vaught is a board-certified maternal fetal medicine specialist and surgical critical care physician. He also serves as the Director of Labor and Delivery at Johns Hopkins Hospital. His focus is in the discovery of treatments and therapies in HELP syndrome, decreasing severe maternal morbidity and cardiovascular diseases in pregnancy. We know that pregnancy puts extra stress on the heart and circulatory system, and because of those risks, it is important for women to pay close attention to their risk factors. Those with an existing heart condition or one that has been developed due to pregnancy need special care to keep a heart healthy and to deliver a healthy baby. We are eager to hear from Dr. Sharma and Dr. Vaught to learn what we should know about heart conditions and pregnancy. Today, we'll have a brief presentation and some questions prepared, but we also want to hear from you. This is meant to be a conversation. We're fortunate enough to have our panelists here with us live. And so for today, they're eager to and ready to answer your questions. And we're ready to have you submit those using the chat feature on this Zoom presentation. You can find the chat button at the bottom of your screen. So to kick off today's conversation, Dr. Sharma and Dr. Vaught are going to start with a brief presentation that highlights the essential elements of managing cardiovascular health during pregnancy and about maternal health statistics. Again, as you are listening, if questions come up, please feel free to put them in the chat. I'll now turn this over to Dr. Garima Sharma and Dr. Jason Vaught.
Thank you so much, Tracy. And this is wonderful, and it's great to be here on this platform with the American Heart Association and Johns Hopkins, and a very warm welcome to my colleague, Dr. Vaught, and my partner in crime in the Cardio-Obstetrics program. So it's great to see you all. Please feel free to populate the chat with any questions that may occur while we're talking about cardiac disease and pregnancy, as well as postpartum care and what mothers and pregnant individuals may need to know. So we're here to talk a little bit about heart conditions in pregnancy and how to identify your risks and what to know about your risks. And this, is a very, very casual conversation. Dr. Vaught, feel free to jump in, and I'll pause and, let you add what you think is important as well in this space. Next slide, please. So I think, just as a framework, we're happy to talk about maternal mortality and severe maternal morbidity, which is Dr. Vaught's area of research. And he does a lot of work in that. Also talk about adverse pregnancy outcomes and what they mean and what you should know when you're getting pregnant. And then also sort of focus very briefly on what the AHA is doing to improve cardiovascular health of pregnant individuals and focusing on health policy changes that help improve maternal health equity. Next slide. I'll let Dr. Vaught jump in here as well. We want to just provide a background on why this is important and why this is an important conversation. I'm a cardiologist. Dr. Vaught is an OB/MFM critical care trained physician, and it's really fantastic to have a combined pregnancy heart team that helps patients get through pregnancy, especially the ones that are at high risk. Dr. Vaught, I'll let you talk a little bit about how women can be helped through the Pregnancy Heart Team and what we do at Hopkins as well.
Yeah, and I really love this slide because it really shows how multi-layered cardio-obstetrics is, and really the role of a pregnancy heart team in improving outcomes, right? And it's kind of spelled out here. You have, first and foremost, you have the cardiovascular disease process that can cause a maternal mortality. However, what we know is that there is a disparity in who can get access to care and who can receive care, right? And so one thing that I think that a pregnancy heart team does is that it kind of creates health equity by giving access to not only a high-risk obstetrician, but also a cardiologist, a trained cardiologist in women's health, that knows to look for the subtle nuances of, or non-subtle nuances, to be honest, of heart disease and pregnancy, right? And by doing that, hopefully we're decreasing disparities that are systemic in nature and that are also endemic in our society, right? So one example would be, because we have cardiology with us and vice versa, our patients that have cardiomyopathies are able to get echoes done, where it might take them 4 or 5 months. You could see how that patient could get frustrated if they have other childcare or work issues and things like that. So, agreed, through these programs throughout the country, it really is taking on health equity and decreasing disparities, which I think is really what will lead to the decrease in SMM.
I totally agree with that. I think, the time that is put in creating a pregnancy heart team or a cardio-obstetric team is so valuable, and such a great service to our patients and their families, in trying to reduce some of the disparities that Dr. Vaught talked about. And why is it important? It's important because United States uniquely is one of the industrialized nations that has the highest maternal mortality out of everybody else, as you see on this graph. When you compare ourselves to all of the other industrialized nations that spend very little on healthcare as compared to what we may be doing, we are much higher, and this data has not changed. It kind of is been like that for the last 2 decades. And so it's really important for cardiologists to work very closely with MFM colleagues, because as Dr. Vaught pointed out, cardiovascular disease is the largest contributor to this maternal mortality. Women in the United States are dying from cardiac related complications during pregnancy. They're also getting hospitalized during pregnancy from cardiac related problems, whether it is arrhythmias or heart failure or valvular heart disease or poorly controlled hypertension. And so having that partnership with our OB colleagues, with our MFM colleagues, really improves the care, and also crosstalk between cardiologists, which really actually helps the patient. Next slide. And, I will let Dr. Vaught talk a little bit about this too, but I'll touch briefly on this. And this is an important slide because when we look at the data, we do a deeper dive in it, it becomes really clear that there is a big racial and ethnic disparity, where Black women in the United States are about 3 to 4 times more likely to die of pregnancy-related cause compared to their aged match and educational match counterparts. So what does that mean? That means that you can click on it again and see if it advances. It basically means that even if you look at an age-wide split versus a racial split, if you're a Black mother, which is the purple graph up here in the US, your likelihood of dying from pregnancy-related causes exponentially increases as you get older. And this is important because it is a focus on the real problem that we're facing, the real challenge that we're facing in the US right now. Dr. Vaught, any other comments on this?
No, I think you hit the nail on the head, right? And I think one of the issues that we are kind of really dealing with is, why is this happening, right? Why is it that, there is such an exponential increase in maternal deaths of Black women when compared to that of, Hispanic white women and things of that nature. And again, it's multi-layered in the process. There's certainly disparities in health, disparities in care. inequitable care, referral patterns that may not be consistent among race and ethnicity. And again, I lean back on that use of programs to help give equitable care, right? If everyone that has a history of peripartum cardiomyopathy or that is over the age of 35 with a history of cardiac disease in your institution or your program goes to a pregnancy heart team, or if we follow the modified World Health Organizations and class 3s and above go to the pregnancy heart team, there really should not be of like, oh, well, I thought this, or like I think it could, and it does help kind of decrease bias in some way. And so again, just kind of like, a very important point and topic.
Yeah. Next slide, please. Yeah, and the point to also mention here is that even if we look at the data from educational status point of view, Black mothers or Black individuals that are pregnant tend to have higher complications, and the mortality rate continues to be higher. So it's, when we say, well, it may be because Black mothers may have an educational disparity, that's not the case actually. And so it makes us focus on what are the systemic issues where a Black mother or Hispanic mother or Asian Native or Alaskan Native mother is less likely to get the kind of care that they should have gotten. So whether it is the impact of adverse social determinants of health that have cascading intertwined relationships with cardiovascular health and pregnancy care, whether it's the impact of structural racism, whether it's the impact of lack of, healthcare access, food toxicity, neighborhood toxicity, all of those need to sort of be accounted for if we are going to reduce the disparity. Next slide. And this is, again, new data that just came out in 2020. I'm sure Dr. Vaught is really very well aware of this, as well as many of you. The maternal mortality actually increased during COVID. We've been watching other diseases increase during COVID and cardiac deaths happening during COVID. And one of the things that kind of get left out is what is the impact on mothers during COVID? What kind of changes happen during COVID for the moms? And I know Dr. Vaught is an ICU critical care doctor, and I'm going to let him talk a little bit about this as well.
Yeah, and so when we talk about the CDC data, we talk about the increase in maternal mortality and SMM, we definitely did see an increase overall, and we saw a shift towards respiratory failure. But what was even more interesting is that there's starting to be more evidence that we also saw an increase in not only preeclampsia, but other hypertensive disorders of pregnancy. And it's unclear if it is attributable to the COVID-19 pandemic, like is there something happening at the receptor level if you get COVID-19, or if it is the severe morbidity associated with non-respiratory illness and maternal health is secondary to the lack of access. We saw an uptick in a lot of women not being able to get to the hospital, afraid to go to the hospital because they couldn't have their partners go with them, or certainly there's that layer of mistrust as well with the medical system. And so I think that this is an area that is still being studied and still ripe for study. Because it is certainly an interesting uptick, and Dr. Sharma's right. It was not only just an increase in respiratory severe maternal morbidity, it was non-respiratory illnesses as well. Maternal.
Yeah. Next slide, please. Yeah, and so this is really, and with this we'll kind of stop and, hopefully take a lot of questions. This was sort of just opening it up to the audience to sort of think about what kind of issues can erupt during pregnancy for an individual that is currently pregnant, and what is the pregnancy heart team actually equipped in taking care of. So if you are a person who currently has existing heart disease, such as a heart valve problem, either a tight valve or a leaky valve, or you have an underlying heart failure or heart dysfunction like a cardiomyopathy that you have been diagnosed with, or maybe a previous pregnancy complicated with cardiomyopathy or a heart failure episode, or if you have disease of the aorta, for example, you're born with a Marfan syndrome or a connective tissue disorder or aortopathy or abnormal aortic size, which is a big vessel in your body, runs in your family, and you know about it, or if you've had some complications with clots in your legs or have a blood clotting disorder, if you have somebody, if you are somebody who has existing heart rhythm abnormalities, such as a fast rhythm called atrial fibrillation, which is fast and irregular, or you've been diagnosed with that in the past, or if you have had heart disease before where you've had a blockage in your heart artery or a part of your heart artery tore from the inner lining, which is a dissection inside the heart artery. And if you were born with a congenital heart problem that was corrected, you can go back to the next slide, please, prior slide, because that will be our end, last slide.
Yeah.
Could you go back to the last slide, please? Next slide. Yeah. And so if those are the existing problems that can complicate your pregnancy, but as Dr. Vaught is very familiar with, is the complications on the right side of your screen, which are all these issues that happen while you're pregnant that may or may not necessarily be a diagnosis that you have during pregnancy or before pregnancy, but may get diagnosed during pregnancy, which are adverse pregnancy outcomes, which our OB colleagues and MFM colleagues are very familiar with. And we know now from all of this cardiac literature and the OB literature that they are associated with long-term cardiovascular impact. They have impact on long-term cardiovascular health. And so in the middle, there are these risk factors which impact both the left side of the screen and the right side of the screen, such as if a woman is already hypertensive, if she already has obesity or dyslipidemia or diabetes, how does that impact both these disorders? And I'm going to let Dr. Vaught complete this up, because this is sort of the focus of where the cardio-obstetrics care really is. It is of women who are currently pregnant, desiring pregnancy, or are postpartum, who have been complicated with all of these disorders.
Sure. And, that's an excellent discussion of, what, not only our pregnancy heart team, but what many pregnancy heart teams encompass. And one thing that I'd like to point out is that one thing that I'm really proud of that a lot of pregnancy heart teams are doing across the country, that women that get preeclampsia, a hypertensive disorder, pregnancy, gestational diabetes, there truly is a continuum of care into interconception care as well. So that means that, you got a diagnosis, like an adverse pregnancy outcome, and now before your next pregnancy, you're seeing a medicine specialist or even a cardiologist if it's necessary, to kind of make sure that you don't have any underlying CVD before going into your next pregnancy, which I think is so important. And I think that gives us a really great segue into a question that we received in the chat that has to do with congenital heart conditions in particular. Would it be appropriate for me to seek services in your department if I have a congenital heart condition and I'm trying to get pregnant? Or do you serve heart disease only? And I think what that person is asking is, do we serve acquired heart disease only? And within our infrastructure, we do serve acquired and congenital heart disease. We actually have an adult congenital heart disease specialist that is a part of our cardio-obstetrics group. And that may differ from institution to institution. It does not mean that what we're doing is like the right way to do it, and what someone else is doing is the wrong way. It's just the environment where it is. There are some programs that have incredibly well-established congenital heart disease clinics, where actually obstetricians and MFMs go to that clinic on a monthly basis to help with pregnancy questions and preconcept consultations and things of that nature. So this is just our infrastructure. But yes, if you were in the Baltimore area or within the DMV area, you would come to our cardio-obstetrics clinic and you would actually see an adult congenital heart disease specialist along with an MFM at that clinical visit. I think another question that we get is, do I need to stay within the cardio-obstetrics clinic or stay within that infrastructure? And I'll lean on Dr. Sharma as well, but I think it depends on what your cardiac disease is. If you are a modified World Health Organization class 1 or 2, which means that you are, like, since we're talking about congenital heart disease, a repaired VSD, those patients do incredibly well. So you might be someone that we see as a consult, might recommend get further imaging in the 3rd trimester, look out for signs and symptoms to look for, but you might not necessarily need to stay versus someone who is someone that has a Fontane's or better yet, their systemic circulation is being supplied for the right side of their heart. And within the congenital world, those patients do stay within our practice, within our clinic. And we are really, along with, Dr. Sharma's team, the sole providers and are involved in not only the outpatient setting, but in the inpatient delivery process, and are usually present for the deliveries.
That's a great suggestion to sort of think about for patients who are currently have congenital heart disease and are desiring pregnancy. Dr. Vaught is absolutely right. A lot of times women who are not currently pregnant, who have existing congenital heart disease, who are desiring pregnancy, like to have a consultation by both an adult congenital heart disease doctor and an MFM doctor in a setting where they can talk about what are their risks of decompensating during pregnancy, or whether pregnancy is safe, or whether delivery will be safe. A lot of these women do come to our clinics as well. And so I think, we'd like to sort of stop with the slides and just open up with any of the questions that you may have, or folks may have, to sort of make this a more interactive decision. And then we thank the AHA for allowing us to talk about these issues.
Thank you, Dr. Sharma and Dr. Vaught. This is a fascinating presentation. I'm looking forward to the rest of this conversation. I'll encourage everyone, if you have questions, go ahead and put them in the chat. We are monitoring and we'll be relaying them to the doctors for them to comment. It's troubling when you hear about the disparity in outcomes for all women in the United States and the rest of the world, and then especially for women who may already be at risk and those who are in minority populations. And as a representative of the American Heart Association, whose commitment is to equitable health, this is especially troubling. So just really appreciate you talking about that. We have some great questions. So let me pull up one here. She says, I'm 8 months pregnant and have been asked to eat a low glycemic diet due to failing one of my diabetes tests and family history. I am craving carbs and sweets. Any good suggestions for tips on what I can eat to curb my cravings?
That's an excellent question. Gestational diabetes is something that we deal with quite often. I'm going to take that question as if someone is confirmed as a gestational diabetic. One thing that I would advocate for you to do is that there are people who are very trained on the nutrition within pregnancy, and many institutions will have a nutritionist within their MFM practice. And so one thing I would do would be to reach out to them. As far as curbing cravings are kind of there for a reason. What I tell my patients, and I hope I don't get a slap on the hand for this, is if you're at a wedding and you have a slice of wedding cake and you've been great the whole week, it's okay. You know what I mean? You're allowed to live. That one surge in glucose does not necessarily create terrible adverse pregnancy outcomes. It's more of the continuum of high risk sugar behaviors, I guess is what we'll call them in the context of this sentence. If you're having cake every day, or the next day you're having a whole bagel, then there might be a problem. But once a week having that delicious sugary sweet is totally, I would say, is fine, as long as the rest of your testing looks good, the growth of the baby looks good, no polyhydramnios. We are human.
Dr. Vaught is making me hungry with this talk. I totally agree with him. I also think that there are certain foods that can give you that sweetness without the excess terrible calories. So I agree with him. Once in a while, if you eat it, it's not bad. It's really the daily behaviors. So if you want to replace some of the sweet fruit during pregnancy, that would be a nice way to honor your sweet tooth without consuming the really bad salty and savory snacks. So fruit is really good. It's sweet. Watermelons is the fruit of the season right now. It's very sweet. It's got a lot of water in it. But again, at the same time, keeping an eye on your weight gain, keeping an eye on regular exercise. The AHA will recommend that in addition to all of the great things that OB and MFM doctors tell you to do during pregnancy, physical activity during pregnancy is still very desired and is very much recommended. And the recommendations do not change, if you're pregnant, unless and until you have a condition that prevents you from exercising. So doing a daily 30 minutes of a good walk that makes you feel like you're going to break out and do a light sweat, and then hydrating is something that you can supplement that cake with.
Yeah, and that will definitely help with the glycemic index as well.
That's a great and I'm sure welcome answer to know that moderation can still be part of good heart health and good care during your pregnancy. We have another great question. This writer says, if your mom had gestational diabetes during pregnancy, is that hereditary or something I should worry about in my own pregnancy?
So, another great gestational diabetes question. We know that women that have a family history, more so of diabetes, as gestational diabetes is certainly associated with it, are at risk of gestational diabetes. That's something that's really important to tell your OB. They may make the decision to do what we call an early glucose screen, and that's doing the glucose screen that you might normally get from the 24th to the 28th week, but having it done in the first trimester. And so really important information to tell your obstetrician. I don't think that we know that there is a direct genetic link where we know exactly what variant is on the gene of the chromosome, but there is an association, and enough of association where, your obstetrician or your primary care physician may say, I know you're only 12 weeks, but let's get an early glucose screen just to make sure that you don't have gestational diabetes right now, or to make sure you're not at risk.
Great advice. Another question that's come in: what are the current questions about the role of lymphocytes or immune system generally in mediating some of these associated risks?
This is a particular area of research that I'm interested in. Not as much, I will be clear with Dr. Russo, but I don't study lymphocytes, but certainly the complement system, if we're talking about immune, especially innate immunity, has really been implicated in preeclampsia. I mean, you can go back and you can look and find C3, C5a, C4, the alternative pathway of complement, not only in preeclampsia, but in HELLP syndrome. The question is, we know that there could be some immune response, whether that is inflammatory in nature, whether that's complement in nature, but what do we do about it? And also too, do we truly understand what's normal in pregnancy? We know that, in pregnancy, the maternal immune system changes, can be quite drastic. There's still a lot of research that goes into that, into looking into that, but it's a great question. We know at some level, the immune system is implicated. I think there are a lot of really smart people teasing out how exactly it's implicated and where are the pitfalls that happen in adverse pregnancy outcomes.
That's such a great question, and I completely agree with Dr. Vaught. I mean, we also recognize patients with autoimmune disorders to be at a higher risk of certain adverse pregnancy outcomes too. So I think there is definitely a link between the immune system and adverse complications during pregnancy.
Good information. Thank you.
I would like to add that we have not found that taking a whole bunch of vitamin C or a whole bunch of vitamin, there have been studies that have looked at that. We have not shown that changes pregnancy outcomes. So I do want to make sure that is related as well. But being healthy, cardiovascular health is a great way to keep your immune system great. So
great advice. So the participant asks, how often should blood pressure be checked during pregnancy?
So, go ahead, Dr. Sharma.
No. So it's a really good question. So if you're entering pregnancy with chronic hypertension, if you already have a diagnosis of hypertension and you are pregnant, then checking your blood pressure during and throughout pregnancy is really important. It's important, and it's also important to be managed and treat your chronic hypertension. And I will let Dr. Vaught talk a little bit about what they've found in their OB literature, which has changed the guidelines a little bit. But from the cardiovascular perspective, our guidelines are very focused on treating our target or a threshold, which is different than what OB MFM literature used to allow. So prior to pregnancy, the treatment target is to get your blood pressure below 140/90 for most individuals, whether they're pregnant or not, and perhaps as low as possible, as low as tolerated. But those guidelines were different when you did become pregnant, where they did allow some permissive hypertension during pregnancy because of some data that, it didn't necessarily make a whole lot of difference in tight control in terms of reducing preeclampsia, or perhaps reduces the placental blood flow and may impact the baby size as they're growing. Now that is data that's no longer true. And so when you have chronic hypertension, the advice is to be on top of it, whether it is home blood pressure monitoring, checking it, a few times a week, logging your blood pressure, engaging your OB doctor and your MFM doctor with this, and taking some preventative steps so that that chronic hypertension does not deteriorate into worse hypertension or the more malignant form, which, Dr. Vaught treats, is preeclampsia. And I'll let him talk about what they've found in their literature.
Sure. And, Dr. Sharma, you've done a great job of already explaining it. You know what I mean? I think that, there is certainly probably going to be, if not already, a shift towards tighter control of blood pressures, with systolic blood pressures less than 140 over 90, and chronic hypertension, women with chronic hypertension. But I think what's also important with this question is it's also good to know what your blood pressures are, or know what your baseline is before you get pregnant. I think what a lot of people don't anticipate is that when you become pregnant, your blood pressures actually change throughout pregnancy. There's a slight increase in heart rate, and then there's a slight decrease in afterload. So there are women who may have been on the cusp of hypertension, like in the, by ACOG guidelines of like being 135 over 80, which by the American Heart Association is hypertension, that their blood pressures drop. They get their first OB visit at 14, 15 weeks, their blood pressure is 110 over 70. And then, at 20 weeks, their blood pressure is in the 150s. And the first thing I ask is, well, do you have high blood pressure? And some people say, no, I don't think so. And you're like, well, when was the last time you got your blood pressure checked outside of pregnancy? And it'll be 3 or 4 years ago. So if you are planning to get pregnant, or if preconceptually, or even if you just got pregnant and you're like 6 weeks, I think it is really a good idea to get what your baseline blood pressure is before the gestation continues. Because as that gestation continues in the first trimester, it can make it, if you do have chronic hypertension, it can make it difficult to establish what that baseline is, especially if you get care into the middle to late second trimester.
It's great advice. I wonder if people are aware at how readily available self-monitoring blood pressure cuffs are, and really how affordable they can be. That it's a device that all of us could have at home to check our blood pressure. And I think, as you're saying, Dr. Vaught, to establish a baseline for us to know that number. The Heart Association would certainly advocate for everyone to know their numbers. And blood pressure is certainly one of those numbers.
Mm-hmm. Absolutely.
As a follow-up question, they're asking, is it always recommended if you have hypertension that you deliver early?
Excellent question. So there are definitely, so like if you, I think it depends on how well controlled your hypertension is. When we look at delivery parameters with hypertension, chronic hypertension and hypertensive disorders of pregnancy, it certainly is within a continuum. Our institutional practice is that if you have chronic hypertension, that you would deliver at 39 weeks or 1 week before your due date. Within the context of gestation, that is not considered early. That is considered a term delivery. It's not even considered an early term delivery. So within our context, we would say, well, you're not delivering early, but you're getting induced before your due date. If you are someone where you're kind of, your blood pressures are not as readily controlled, like you're on multiple medications, then that does start to bring up, okay, we're going to deliver you early. Like if you're on labetalol and nifedipine and we're adding hydralazine and you get to 36 weeks, you may say, okay, when you get to 37 weeks, we're going to schedule you an induction of labor. I do think it's important to say this: having hypertension and having a hypertensive disorder of pregnancy does not mean that a C-section is necessary. And I think that's really kind of like a conversation that, we have sometimes with our patients, that especially ones that have maybe delivered before, that have had hypertensive disorders or pregnancy or hypertension. They say, oh, I had hypertension, so I had a C-section. So you don't necessarily need to have a C-section just because you have hypertension. Now, there may be other contextual things that go along with having hypertension that may have necessitated the C-section, but having hypertension alone is not an indication for a cesarean section. But it can be an indication for a term delivery before your due date, or even an early term or late preterm delivery, depending on how difficult to control your hypertension is, and also other comorbidities. Like if you have, if you're in Dr. Sharma's clinic and you have hypertension and you have an ejection fraction of 30%, that's a very different context than someone who has hypertension and a normal ejection fraction.
Great answer. And to the follow-up, I think we have a nurse with us on our participants today who says, I often get the question from postpartum patients who had preeclampsia during pregnancy, if they should continue to check their pressures. These are not instructions that are regularly included in discharge. And I currently encourage those patients to check daily and look out for HA, BV, or chest pain. Also secondary to this is 6 weeks too long between delivery and a follow-up visit with the OB.
I will take a stab at it, and I'll let Dr. Vaught answer the OB part of it as well. I think this is a great question, and I appreciate our nursing colleagues for providing a lot of support in the postpartum timeframe to our patients during pregnancy as well as in the postpartum, but specifically in the postpartum timeframe because of all the help that they are able to provide it in a multidisciplinary fashion. Blood pressure can fluctuate a lot postpartum. It happens because you, in the first 40 weeks, you are pregnant. There are different physiological changes. Once the baby's out and the placenta is out, the body is trying to go back to its usual physiological state. At the same time, you have a newborn baby. You're trying to breastfeed. You're also trying to recover from the pain of a delivery, whether it's a C-section or it's a vaginal delivery. There's a lack of sleep. There's a lot of different factors that impact blood pressure and variations in blood pressure in the postpartum timeframe. And having that education that blood pressure is not a standalone one-time number. It changes diurnally, changes during the day, changes during the night. And having a good sense of what it is once a day and trending it is the best way to get a sense of what what your particular trends are. Having that is helpful. Sometimes in some individuals, the blood pressure returns back to normal after a preeclamptic pregnancy pretty fast. Within 3 to 6 months, they're normotensive, their blood pressures return back. But then we also have data that in some individuals that does not happen. And that's why we recommend extended monitoring of blood pressure, because sometimes it's one of the easiest things you can do to keep a trend of your blood pressure. And if it is high, then to be treated for it, because if you're not, that is one of the bigger reasons to actually decompensate and have heart failure or be readmitted or have a stroke in the postpartum timeframe. And so having a very close eye on it and treating that is important. And the last thing before I let Dr. Vaught talk about the second half of the question is that there are times where the blood pressure normalizes pretty quickly, but even late postpartum, it may rise again. And that's why it's really important to continue all of the healthy aspects of management of blood pressure: diet, exercise, sleep, nutrition, non-smoking, and also screening for other disorders such as postpartum stress disorder or postpartum depression, which can be associated with these outcomes as well.
Yeah, I have very little to add to that. That was really, really well said. I think there was one question of, is 6 weeks too long to follow up? And I mean, I think most people would say yes, if you have a hypertensive disorder of pregnancy, and many institutional infrastructures in practice now are to have a 1 to 2 week blood pressure check to actually discharge the patient home with a blood pressure cuff if they don't have access to a blood pressure cuff, and to do blood pressure cuff teaching, and to make sure that they know a number to call if there are certain numbers that are concerning. So a lot of change in institutional practice, which has come from changes in policy, which I think has been truly remarkable.
And we have a follow-up question. What is the best time of day to check your blood pressure?
I can take that. There is no best time. I think you need to pick a time and stick to that time. And, and I think whatever you can remember, if you are someone who is an early riser, who has a blood pressure cuff at your side table and remember it that way, then check it in the morning. If you're somebody who isn't, someone who wants to do certain chores and then wants to come back at the end of the day or midday and check their blood pressure, but stick to it. So, I mean, it's important to recognize that, morning blood pressures are going to be different than late blood pressures. And I think if you want to have a good trend of how it runs throughout the course of the day, check it in the morning and check it at night, but don't check it hourly, because that's another area of anxiety provoking, and it's not feasible, and it's not something that we recommend. Pick a time that works for you, personalize it, make sure you trend it so that it is more reflective of what you do. However, I will point out that if you're checking your blood pressure, don't run a marathon or, to run outside and come check your blood pressure. It has to be when you are in a steady state, quiet, sitting down for 5 minutes, not talking, reflective of what, you would be without being anxious or worked up, because otherwise, there's a lot of fluctuations, which leads to a lot of confusion.
Thank you, Dr. Sharma. So this listener is asking, as a CHD patient, I know my child has a heightened risk of having a heart issue of some kind. What type of diagnostic testing and early treatments are available to address these risks or potential diagnoses?
So yeah, I can take that one. So, it's actually within our guidelines for mothers or birthing persons that have a history of a personal history of congenital heart disease. Those women will get, or those birthing people will get a screening fetal echocardiogram. That can either be done by a maternal fetal medicine specialist who's trained in it, or by a pediatric cardiologist. Again, there's no way that's the right way or the wrong way, but it is the institutional practice. Many times, adult congenital heart disease specialists, if their patients get pregnant, will go ahead and schedule them for a fetal echo as well. If your neonate or if your fetus does have a congenital heart disease, after the screening echo, then of course that would depend on what type of heart disease what type of congenital heart disease they have, and all of those sorts of things. But yes, at 20 to 22 weeks, many institutions, if not all, will do a screening fetal echo after the anatomy scan to confirm or to screen for congenital heart disease.
Thank you, Dr. Vaught. So this listener is asking, are there any female-specific disorders that increase a woman's risk of heart disease?
Yes, and I can take that and then let Dr. Vaught also comment on it. But there are. So, I mean, when we're looking at traditional risk factors and non-traditional risk factors, traditional risk factors for heart disease that are recognized and a part of cardiovascular health assessment are hypertension, diabetes, high cholesterol, smoking, physical inactivity, and then there are these a spectrum of evolving non-traditional risk factors, and adverse pregnancy outcomes, particularly preeclampsia, is recognized now by the American Heart Association and American College of Cardiology guidelines as a sex-specific risk enhancer for both short-term and long-term cardiovascular risks elevated in these women. In addition to that, preterm birth is, because many times preeclampsia is associated with preterm birth, is also in that spectrum. Polycystic ovarian disease or syndrome, premature ovarian failure, early menopause, that leads to shorter, period cycles and complications. That these are all sex-specific risk enhancers that are associated. Infertility. The question really is, what is it in these individuals that once that happens changes their trajectory, and how does it change it? And I think the guidance with that is still out there. We're still trying to use precision medicine, understanding biomarkers, understanding endothelial dysfunction, understanding the health of the arteries and the vasculature in those individuals to understand what increases, what changes in them in the postpartum timeframe that elevates their risk, or it's merely that the individuals who actually get this are also at high risk of getting that anyway. For example, they would already have underlying poor cardiovascular health. So we don't really know. I think the truth is sort of is that it doesn't matter at some point, because I think if you know that there is enough evidence that there is a risk which is associated with a poor outcome, then you try to rectify the aftermath of that risk, right? So still controlling your blood pressure postpartum, having a healthy diet, controlling your diabetes, controlling your blood sugars, controlling your cholesterol, not smoking, getting enough sleep, having good mental health is still just equally important whether or not you have those risks or not.
So would you say that heart health should be evaluated in all pregnant patients?
I'd like to answer this in a slightly different way. I think that heart health is extremely important in pregnant individuals and pregnant patients, because we know this, that if you have poor cardiovascular health or poor risks, you tend to do poorly during pregnancy or have some complication. You meet with your OBs so many times. They are really equipped in giving you basic information about what you should do. I think if you're concerned about your cardiovascular health, you're concerned about your heart, advocating for yourself and having that conversation with a cardiologist or cardiovascular clinician is still important. Because sometimes you get reassurance, sometimes you get access to information, sometimes you get diagnosed with something that you may not know. So evaluating heart health, especially in those who have higher risks, have had family histories of cardiac problems, have had personal risks of cardiac problems in the past, or generally are worried, I think would be helpful. Maybe it's a little biased.
Thank you, Dr. Sharma. So I'm going to ask just one more question from our listeners before I give each of you time for some final thoughts. So if someone has a pre-existing heart condition, would you generally recommend against a home birth?
I will take that question. I think, I think it is really important to kind of make sure that at the forefront of this, where there is reproductive justice, right? And reproductive justice really encompasses not only getting access to not only contraception, abortion services, and birthing services, but it's really kind of hearing our patients and knowing how and where and when they want to birth, right? And so I think that's really important. I think that should be in the forefront of it. Now, in saying that, in the context of that, there are certain medical complications that can happen where you really want to have access, because again, within this reproductive justice, access is a part of it, right? And so if we're keeping the reproductive justice at the forefront, you want someone to have the birthing experience that they envision, but you also want them to have the access to the care that they may need. I'm not going to say yes or no to home birth. That is a totally different webinar and a totally different topic, but I will say that if you have cardiac disease that requires continuous telemetry or continuous cardiac monitoring, that requires diuresis within labor or immediately after labor, that requires any sort of medication to either bring down your blood pressure or bring up your blood pressure, I don't know how you would do that at home, right? And that is really me. I think that's our system and our infrastructure trying to be like, we really are trying to be purveyors of reproductive justice. And part of that justice is making sure that you have the access to the care that you need to have a safe delivery. And that is actually how I'll answer that question.
I think there's a lot of insight and compassion in that answer. Thank you, Dr. Vaught. So I'm going to ask each of you in turn. Dr. Sharma, I'll come to you first, just for closing thoughts as we end our time together today.
Yeah, no, this has been great. I appreciate the HA in raising these issues. I think it's really nice to hear our MFM colleagues who work very hard and every day in preventing poor outcomes. We are here to help them. And I think from our perspective as a cardio-obstetric team, we're here to sort of help women understand their risks during pregnancy, understand their risks from a poor pregnancy outcome, so that if they are in the postpartum timeframe, first of all, we wanted to get them through a regular, pregnancy and safe pregnancy. But once they do become postpartum, to also be very empowered to understand their personal risks and change their lifestyle and change their trajectory. I've learned this from Dr. Vaught. He's, over the last many years that we've known each other, many times these women who come to get delivered probably meet cardiologists and MFMs for the first time. And so it is our responsibility to be kind, to be inclusive, to understand their social determinants, to provide them with all of the information that we can, so that not only is their outcome good, but also they're empowered and they do feel like they trust the health system and they trust their doctors and are invested in their care. So that is actually really one of the benefits of seeing both MFM and cardiologists if you have a heart condition, because you can leave with a lot more information than you would have had otherwise.
Yeah.
Thank you. And Dr. Vaught, closing thoughts?
Yeah, I'm gonna really just kind of piggyback on what Dr. Sharma said. I think she said something that's really, really critical, and that I've learned a lot from you as well, Garima. But you said something that really spoke to me. For a lot of our patients and a lot of our birthing and a lot of these families, we are actually the first interaction with an inpatient hospital setting, right? Of course they might see their pediatrician and things like that and get their allergy shots or whatever it is. But for a lot of birthing persons, their pregnancy or their delivery is really the first time that they're truly going to be an inpatient, meaning being admitted into the hospital, or the first time that they have a complication from a cardiac condition or a newly diagnosed cardiac condition really may be their first time. And so, the way that they're treated and the trust that we're able to form in that first time period really affects their future health. If a patient had preeclampsia and during her care, she didn't feel like she was heard, she didn't understand why she was delivered early and her baby went to the NICU, 10 to 15 years from now, when she has chest pain, she may not go to the hospital. She may say, I don't want to go back to that hospital. Last time I went to the hospital, I got admitted, I got a C-section, and my baby was in the NICU for 6 weeks. And so really that education and that trust, I think, is so important. And we need to remember that we really are the first time that many of these patients are really experiencing an inpatient admission. And that trust that is gathered there is incredibly important.
That's very insightful, Dr. Vaught. I've worked for the American Heart Association for a long time and had the honor and privilege to work with many physicians who are volunteers and advocates for the American Heart Association. And what I have found overwhelmingly is that physicians want what's best for their patients, and that they come to their job and to their calling with an enormous amount of empathy and compassion. And that certainly is coming through from both of you. So thank you so much for your time today and answering these questions. As we finish out today's program, there will be contact information on the final slide. So if your question didn't get answered and you'd like to still submit a question, we're happy to take that. And I know Dr. Vaught and Dr. Sharma will be happy to answer. And also this program was recorded today and will be available. So if, as you were listening, you were thinking about a friend or a relative who you think would benefit from having heard the conversation, we'll be sharing out that recording. It will also be available on the Johns Hopkins Medicine website, as well as the American Heart Association website. So it can be shared widely and others can enjoy it and learn from it as well. So today's presentation has been a collaboration between Johns Hopkins Medicine and the American Heart Association as part of our Live Fierce collaboration in the community. And so we thank you, Dr. Sharma, Dr. Vaught, and certainly Johns Hopkins Medicine for your work, your commitment to building healthier lives in our community. Thank you.
Thank you so much.
Thank you for inviting us.